Hello, we are glad you could join us today for the ECG webcast, Improving Margins Through Value-Based Payments. Are you leaving money on the table? I am Sandy Meyerson, an Associate Principal at ECG, and I am pleased to be your moderator for today's program. To reduce costs, improve the health of populations, and enhance the patient experience, healthcare organizations are increasingly incentivized through value-based payment arrangements that tie reimbursement directly to clinical quality metrics. While CMS's value-based programs are a zero-sum game, commercial payers often negotiate incentive payments directly with the organizations to achieve predetermined benchmarks in quality outcomes. So, how do complex healthcare organizations ensure they achieve negotiated quality outcome targets and not leave money on the table? We are glad you could join us and for this interactive discussion with clinical leaders from the Medical University of South Carolina as they share their approach to improving performance and quality metrics. Today, you will learn more about the healthcare industry's move toward value-based incentives and the tactics MUSC is using to engage teams, drive improvement, and overcome challenges to maximize incentive payments. We will also explore how payer contracts have evolved to include value-based incentives for achieving quality benchmarks and give you an insider's perspective into MUSC's approach to achieving quality performance goals through a tightly integrated and effectively governed QAPI program. And we will examine approaches to monitoring and communicating performance through the use of scorecards and other dashboard approaches. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 60 minutes in length, which will include 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handout, but if you were a late registrant, you can download the handout in the handout page on your screen. Attendees are participating in listen-only mode. But if you have questions, you can type them into the questions pane at the, and we will address them at the end of the formal presentation, and you can enter those at any time. If we are unable to answer all the questions today, we will follow up with you after the session. We will be launching an audience polling question during today's program, and we hope that you will participate in this interactive measurement tool. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete this survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Joining me today is Kim Adelman, a manager in our performance transformation practice at ECG, where she expertly leads the implementation of new and improved care delivery processes, particularly under alternative and bundled payment models. Before joining ECG, she was the executive director of the musculoskeletal and neuroscience service lines at Mission Health, where she oversaw strategy development and operations for multiple centers of excellence across a 7-hospital system. Kim is a fellow in the American College of Healthcare Executives and has been both a contributor and a peer reviewer for ACHE's Journal of Healthcare Management. She is also a senior examiner and team leader for the Malcolm Baldrige National Quality Award program, serving on the Board of Examiners for the past 7 years. Dr. Danielle Scherer is an adult hospitalist physician and the Chief Quality Officer at the Medical University of South Carolina Health System. Dr. Scherer first joined MUSC as a hospitalist and then practiced as a hospitalist and medical director of the inpatient medicine services at Brigham and Women's Hospital in Boston for 5 years before returning to MUSC in 2010. She is a certified trainer in Just Culture and Team Steps, is a Lean Six Sigma Black Belt, a Baldrige National Examiner, and a certified mediator. As MUSC's Chief Quality Officer, Dr. Scherer oversees all quality, safety, population health, patient experience, and regulatory efforts for the health system. Patterson Birch is the Director of Quality Reporting and Improvement at the Medical University of South Carolina. She has a background in quality and information solutions and has had responsibility for numerous regulatory programs at MUSC. Patterson is certified in Business Relationship Management and Information Technology Service Management. As the Director of Quality Reporting and Improvement, she oversees MUSC's CMS and the Joint Commission's regulatory reporting programs, serves as the subject matter expert on public reporting and ranking programs, and collaborates with specialty and quality leaders across MUSC on performance improvement initiatives and opportunity closure. Dr. Nicole Pilch is the Medical University of South Carolina's Director of System Quality Assessment and Performance Improvement Program, known as QAPI. She also maintains a clinical practice in the outpatient kidney transplant clinic and is a professor in the Department of Pharmacy Practice and Outcomes Sciences in the MUSC College of Pharmacy. Dr. Pilch has served as a primary investigator for several clinical trials, both investigator-initiated and industry-supported, and published several articles and book chapters regarding immunosuppression practices, patient safety, medication adherence, process improvement, and the role of the transplant pharmacist. In her role as System QAPI Director, Dr. Pilch is responsible for leading and directing overall quality improvement activities across MUSC. So with these introductions, let's review today's agenda. So in today's webinar, we are going to talk about and present the shift to value. We will discuss overcoming organizational challenges. Our colleagues from MUSC will share with us how they identify payer and rankings-based quality gaps, approaches to closing those gaps, and ongoing challenges. We'll finish the webinar with some success factors and then close out the session with questions and discussion. And with that, I'll turn it over to Kim.
Thank you, Sandy. I want to start by providing a backdrop of why today's topic is becoming more and more important. Many payers are following Medicare's lead and are now tying payment to quality metric scores and the associated performance. While we don't have 2020 information on value-based payment adoption because of the pandemic, you can see here that from 2016 through 2019, straight fee-for-service reimbursement has declined from 62% to 39%, and the shift toward value is continuing, whether that's through fee-for-service with associated quality incentives or alternative payment models such as shared savings, risk, or capitation arrangements. COVID has helped accelerate the shift towards value in conjunction with several other drivers, such as commercial payers adopting site-neutral payment in order to manage costs, a growing vulnerable aging population that's requiring more focused case management to ensure quality outcomes, the adoption of digital health in order to scale access and meet consumer demand, and the federal government initiative supporting alternative payment models and revised physician self-referral and anti-kickback regulations. So long story short, we continue to see this accelerated shift towards value-based payment and anticipate that continuing in the future. On slide 7, you can see this continuum of value-based care delivery from least risk, fee-for-service on the left, to more financial risk on the right. Many organizations are still in the developing stage with fee-for-service and some pay-for-performance as the majority of their reimbursement strategy. Those in the transitional stage are getting into shared savings and shared risk arrangements. And the furthest to the right are those highly evolved organizations that are assuming full risk for entire populations. As an organization moves to the right on the continuum, there is more focus on managing total cost of care, which ultimately requires heightened focus on clinical and financial integration and associated higher levels of commitment and provider accountability. At this point, I'm going to turn it back over to Sandy to launch our polling question.
Thanks, Kim. Our polling question should be appearing on your screen, and the question reads, where is your organization in the continuum of value-based care delivery? Please select one of the following responses: developing, transitional, or highly evolved. And if we think about what Kim shared, developing is really you're in a fee-for-service and some pay-for-performance arrangements. Transitional is you've embarked onto the shared savings and shared risk arrangements, and highly evolved means that you really are all in with full risk. So we've had some good responses. We're still letting folks weigh in. We'll give it a few more seconds and let folks tell us where they are in their value-based care delivery evolution. Very interesting. Excellent. Okay. So we've had good responses. So let's close the poll and share our responses. Let's see, 32% of respondents said they were in the developing phase of value-based care delivery, 55% in the transitional, and 14% are highly evolved. Kim, any thoughts on these results before we jump back into the presentation?
Sandy, I'm not surprised that the majority of our respondents are falling into either that developing or transitional category. We're finding very few organizations that are highly evolved at this point on the value-based care delivery continuum. Let's go ahead and jump back into the presentation, where you can see here that because the shift is not happening in a linear fashion, many organizations will be in different stages depending on existing versus new payer contracts and other competing priorities. Depending on where you are in the continuum, there will be different drivers, such as meeting metrics in order to avoid penalties, or managing total cost of care, or a combination of both. And also a myriad of challenges ranging from having standardized measurement systems and data management approaches to inappropriate clinical variation. Challenges really being in any or all of these three at the same time. We'll hear in a few minutes how MUSC is tackling that situation. But before we do that, as you'll see on slide 11, here are some common opportunities for improvement that ECG is finding while working with healthcare organizations such as MUSC to achieve the full value of their incentive payments. Most of the gaps when you're trying to move to the right on that continuum are related to reducing clinical variation, having transparent real-time data accessible, and dealing with all of the competing priorities, whether that's across your organization or in the market. Oftentimes, the people challenges that you see here on the left revolve around a general lack of awareness of specific incentive programs or targets. People just aren't aware of what those targets are. The pandemic has had an impact on people resources and prioritization of work in this arena. And oftentimes there are also misaligned incentives. From a process perspective, the challenges are typically around inconsistent or variable approaches, including the use of evidence-based protocols and order sets, and also the lack of transparent, validated, and trustworthy data to drive improvement efforts. And in the technology bucket, many organizations have barriers with being able to timely scale analytic and EHR solutions, or some may have too many BPAs that result in alert fatigue and providers are ignoring them. And then there's typically a lack of standardized documentation. You may see some familiar things on this slide that you're dealing with in your own organization. Moving to slide 12, ECG has developed a framework that we use to assess organizations and help them evolve in this space. You can see here the 6 areas of focus that should be considered and addressed to set up your organization for success under value-based reimbursement. The first being provider alignment and developing a comprehensive provider network that's built to meet population needs, as well as being financially accountable. Care delivery transformation requires coordination across larger patient populations, focusing on evidence-based practice. Robust technology is needed in order to develop more longitudinal records of care and centralized value analytics. Effective payment models might include upside and downside risk, direct to employer or direct to payer, collaboration, and capitation arrangements. Aligned provider compensation with performance bonuses tied to quality and value-based compensation aligned with payer contracts is important. And lastly, and probably most important, is a strong organizational foundation with quality committees, formal, active population health management with designated leader and a formal structure in place. And we'll hear here in a few minutes how MUSC is navigating this shift and addressing quality performance gaps. But here on slide 13, we wanted to highlight how the use of dashboards and other scorecards can be a real integral part of addressing care delivery transformation across conditions, service lines, and various patient populations. These tools can also assist with alignment of value-based provider compensation models. By combining this visibility of performance with a strong quality or population health management structure, such as what MUSC is building, that helps you ensure that you're not missing pay for performance targets and leaving dollars on the table. Keeping score in real time, even though pay for performance incentives are typically based on lagging data, helps ensure that your organization can meet incentive targets in the future upcoming performance periods. It's kind of like keeping score in sports, right? You have to keep score, monitor statistics, use that information to help with improvements so that you can be a winning player or winning team in the future. The important thing is monitoring performance more often than just at an annual scorecard, if that's what you're receiving from your payers, or through lagging publicly or otherwise reported data. Something else to consider is that you need to understand the value-based calculations and definitions that you are being held to in order to ensure that you're measuring the same thing. This might mean different slices and dices of dashboards, or having to create a real-time proxy dashboard for different programs or payers in order to understand how your performance will impact your reimbursement opportunities. On slide 14 are some key steps to help in the development of credible real-time performance dashboards. With all the limited resources and competing priorities, you want to ensure that your efforts are resulting in useful tools that are easily accessible, that your people are utilizing regularly. So first, you want to assess your source of truth. Is your EHR the source from where most data is originating? And how are you accessing your quality metrics? Are you only able to get them when they're shared by that payer? And are there real-time reporting capabilities? Once you do that assessment, then you have to refine your source of truth, creating an inventory of in-scope quality measures and integrating those quality measures into your EHR that will then flow into an analytics dashboard. As an interim step, we encourage people to collaborate with your commercial payers, request that those payers provide you more timely, regular patient-level details so you know how they're keeping score as well and can shift gears if you need to do that. And then you need to collaborate with your IS department and coordinate and prioritize resources in order to accelerate reporting and real-time capabilities. And if you're using external analytic partners, you will need to collaborate with those folks as well. Once you've established the reporting capabilities, you'll see here on slide 15 that it will be important to determine how best to segment and utilize the performance data. Here are a few examples of how performance data can be segmented in order to identify specific areas for improvement and also make sure results are sustained. That's where the trending comes in over time. We oftentimes see great results during a focused improvement effort that then drop off when that focused effort gets shifted to the next priority. It's important to keep an eye on that performance, revisit often, establish a cadence in order to maintain those gains and communicate that to your team that you're working with. Moving to slide 16, transparent provider level dashboards or scorecards are also extremely important when you're trying to tackle clinical variation. Tracking provider compliance with the use of agreed upon evidence-based protocols, and then creating a forum to regularly review and discuss that with providers is key to identifying opportunities for improvement, problem solving, and ultimately changing behavior if that's what's needed, so that your results can be more consistent and improve on quality metrics such as surgical site infection rates like you see here. I can tell you that some of the most productive conversations I've witnessed are when you have a group of providers in the room looking at outcomes data, looking at the evidence-based protocols, and having robust conversations around how they can improve performance and sharing tips with each other. I'm going to now turn it over to Patterson so she can introduce you to MUSC and the approaches that they're using to improve performance on their journey to achieving full financial incentives in the value-based arena.
Thanks, Kim. Patterson Birch here. So the Medical University of South Carolina is a large academic medical center located in Charleston, South Carolina. In addition to our main academic campus there in Charleston, we also have 4 community acute care facilities across the state, each bringing their own flavor of demographics and patient populations to which we serve. We also have 2 nursing care facilities as part of our community hospital network, and a rehab facility as well located within our Florence Medical Center group. A few of our awards and recognition there on the right-hand side. But as we, I guess, look across the landscape in South Carolina, we have seen a robust amount of various programs in which healthcare facilities are either required to participate in and or have electively participated in or decided to participate in as the landscape of payment reform has kind of been introduced over the last 10 or so years. Some of those programs will be listed there on slide 19. And I think that if you're working within the quality space or even just at a healthcare facility in general, none of these programs and or evaluators of quality will come as any surprise. But it does create a huge burden on healthcare facilities in order to ensure that not only are they providing high quality, high value care, but are they playing the game right in regards to making sure that they're avoiding penalties, achieving that letter grade and or star rating that makes them look as good as they know they are, and avoiding penalties and bringing extra dollars in the door. So for today's purposes, we'll be kind of reviewing what our strategy is in regards to taking in this landscape of a million different quality metrics and how we have been able to set ourselves up for success with working with our clinicians and making sure that we're focusing on the right quality improvement initiatives across our organization. So with that, a few of our key strategies for identifying the right gaps are listed on slide 20. So from a starting place, you know, a lot of these programs look and feel similar to one another, so there may be slight differences in between a measure definition here or there, depending on if the payer is Medicare or if it's a private payer. So what we've really tried to do is develop a comprehensive measure or KPI inventory to kind of simplify things and make sure that we've got a comprehensive list of what all we need to be looking at. In addition to that, we've also, which kind of touches on some of what Kim mentioned earlier, developed a report repository, which includes all of the various reports that we use to track quality outcomes or metrics. And through that, also developing standard operating procedures, or what Nicole calls SOPs. She's beaten that into our brain for the last year plus, and it's really kind of revolutionized how we approach reporting within our organization. So when you approach a report, are you following the right steps to ensure that you get the data that you're looking for and you're going to the right report? Because we have, as many of you I'm sure do with the big data situation, tons and tons of data is out there. So how do you actually leverage the reports that you have at your fingertips in order to find the right data points to influence change? We are also on a constant basis analyzing performance, comparing ourselves to peer groups and benchmarks to ensure that we're hanging with the pack and focusing in on some of those opportunities where we may be falling behind to some extent. And then across programs, we really have been trying to target what we've kind of coined our heavy hitters. So these are measures that are relevant to a number of different programs that have a significant influence due to weight and or prevalence within the healthcare industry that will influence the overarching score and or ranking. So what measures do we see across numerous programs that are really heavily emphasized from an outcomes perspective? Performance opportunity compared to peers and benchmarks. So I kind of already touched on that, but just making sure that where we are falling behind the pack, let's make sure that we get a group around looking at that across our facilities, streamlining our best practices and making sure that we are honing in and making sure that we're focused on improving like the pack is. And then also, because we are healthcare providers at the end of the day, making sure that if there is any kind of patient safety situation that arises, those are the types of situations we need to hone in on and focus on as a high priority, given that, one, they are relevant to a number of the programs, but two, at the end of the day, we must provide safe and high quality care to our patients in order to do our due diligence. So with that, I'll turn it over to Nicole, who will kind of give you a little bit more insight into our governance structure and how we've approached things.
Thanks, Patterson. So I'm sure, like everyone on the call, the challenges of COVID-19 were ever present and still probably lingering. We were fortunate enough to sort of take the lemons of COVID-19 and turn them into lemonade with kind of redoing our governance structure for quality. So we were able to take our resources within quality and safety and combine them in such a way that we could develop a good horizontal and vertical structure so that we could take the KPIs vertically within each of our service lines or ICEs and ensure that our key partners on the operational side knew what they needed to do, knew how to measure it, and knew how to action those items and develop process improvement projects that can then be used on the horizontal. So when we found something that worked in one of our ICE or service line areas, we were able to bring that over into another area and horizontally cross-pollinate and really provide that additional collaboration. So you can see on this slide where we have system quality at the top, and then we have the division quality executive committee, and then the individual service lines or ICEs with quality and safety expanding the horizontal. And the key driver here was really the development of our quality and safety manager group. You can see that in the middle of that sort of figure that looks like a flower. The quality and safety managers are aligned with each of the individual service lines and are partners with the ICE leadership, external reporting, risk safety, the Value Institute, and then our operational partners. And we'll go into a bit more detail here on slide 22. So you can see here the system quality managers oversee these various areas from perioperative all the way to surgical specialty and everything under that umbrella. And they roll through the system KPIs such as mortality, length of stay, readmissions, and safety, and then those ICE-specific KPIs, so the population-based attribution. So for example, in our heart and vascular area, we do a lot of work with heart failure, which I'm sure multiple centers do. In our surgical specialty and spine area, we're diving into the spine center. And then also in places like musculoskeletal, we're using our joint replacement program through the Joint Commission as some of those ICE-specific KPIs that also cross-pollinate into the system. And then safety obviously is aligned with all of this. So we have our patient safety intelligence or our reporting system for patient safety that we review on an ongoing basis, and also look at our hospital-acquired conditions and do some of that common cause analysis, along with rolling all of these factors into QAPI that meets at a specific cadence within each one of the ICEs. And we utilize the cross-pollination, so if we need to have some perioperative input in, say, the heart and vascular ICE, those quality and safety managers can collaborate on that horizontal continuum to develop process improvement. On slide 23, we can kind of demonstrate a bit of an example about this. So one of the areas that we've had some pretty good success where we are integrating across our quality system is our noncompliance with the sepsis bundle, or the SEP1 measure. And we defined it as being able to determine the scope of the issue with sepsis. We had a task force that had been meeting for a while, but we really weren't able to gain traction. So we sort of redid the key informant interviews and identified all of the data points and gaps in the current measure process. We had some definition confusion, some order set non-use, some incomplete chart documentation, and significant care variation. And that's when we moved in and really dug into the data and did some chart reviews and analyzed these process gaps. And then we were able to improve by developing a standard operating procedure for our abstraction, and we were able to share that with the clinical team so we knew when time zero would start. We knew where we were going to pull each one of those variables out in order to make sure that we were adhering to the sepsis bundle, and then being able to identify the gaps that we could help really improve and develop process improvement projects. We increased our sampling denominator, and then with this retrospective case review, we were able to take these cases directly back to the clinical team and really dig into the data so they could see and identify the improvement opportunities that we needed to implement. We also revised our order set to ensure documentation, and then in the hopes of reducing care variation, we're going to be prospectively looking at this data in a dashboard fashion so that we can ensure that all of our process improvement project ideas and KPIs are implemented. And we're really going to utilize some of our systems and teams that are already in place that potentially could be extenders for us. So we have a rapid response team that identifies patients on the floor specifically that have some specific issues that would trigger them to be at high risk for developing sepsis and or other rapid response indications. And so having those MUSC rounders walk around to these patient rooms and help implement the sepsis bundle earlier will hopefully improve our overall inpatient mortality. And on slide 24, you can see that we did kind of reach the tip of the iceberg here. Just in our deep dive and chart review, we're able to improve our overall bundle compliance pretty significantly in the first quarter of 2021. And we're looking forward to that continuing through the rest of the upcoming fiscal year. And I'll hand it over to Dr. Schur to finish out the section from MUSC.
Wonderful. Thank you so much. That was a great example of what our governance structure has evolved into. And again, the whole point is to support this evolution to full risk. So what I'm going to review is just a couple of our ongoing challenges. As Kim mentioned earlier in the webinar, these really all fall into that same triad of either people, process, or technology. So one is, there's a whole myriad of payers and rankings, many of which Patterson reviewed. Each have different formulas and metrics and point systems. And so trying to, again, review all of those and get them synthesized for the masses and, re-communicating those as they change is really a significant challenge. I think it's difficult enough for the quality team to track and trend all of these. But to really keep your stakeholders engaged across different divisions and ICE, as we mentioned, can be very challenging. As well, in that second bullet point, our payer dashboards typically change at least once a year, some even more frequently. From an IS or technology perspective, it's also been difficult with all the different payers to have a consistent process for exchanging data. In that same vein, in the next bullet point, payers typically use claims-only data, which gives them an incomplete picture of what's actually happening in the patient care arena. And so the need for constant data exchange is really important to give them a complete picture of what's actually happening on the clinical side. As well as we know, there's always going to be competing quality priorities. As Patterson mentioned earlier, we try to, get at what we call the heavy hitters, but there's always other things that are outside all these payer programs that are extremely important, both to our team members as well as our patients. We have emergent patient safety issues that come up, more frequently than we like, and trying to balance these, what I sort of call top-down versus bottom-up priorities. The top-down being what do payers tell us we have to do, and the bottom-up is what do our care team members see as valuable and important, and really balancing all of those in all these competing priorities. And of course, COVID certainly outweighed all other priorities and really made it even more challenging. And then this is in a milieu, as we know, of limited resources. We all know that to be true, that revenue sources are constrained regardless of what the payer type or relationships are. And not just for the quality team, for our information solutions and our clinical teams. I would certainly say, and not unique to MUSC Health by any stretch, but 2020 certainly was a challenging year across the board, and many of our teams, based on our recent employee engagement and culture safety survey results, are really telling us that their stress and staffing levels were at sort of an all-time low. Again, not unique to MUSC Health, but it really does take strong leadership and governance to weather that for our teams. The last two, I would say, are also probably not unique to MUSC Health, but one area that we've struggled a little bit is deep claims expertise. So again, it takes a little bit of both people, process, and technology to get really good at claims. A lot of healthcare systems are not, because they're not on the payer side, that is not an area of deep expertise. We are gaining that expertise, obviously, because we have to, but it does require, again, both people, process, and technology to get really good at that. And that does relieve some of the burden of some of the other challenges that I mentioned earlier. And then last but not least, and kind of goes without saying, but MUSC Health, as well as other healthcare systems and centers, are undergoing constant growth and change in services, different populations, again, which ebb and flow based on the payer, which again makes this myriad of ever-changing numerators and denominators, if you will. So that's hopefully a pretty good summary of where we are, how we try to prioritize our work, how we govern our structure. We do feel very confident, and again, based on our sepsis example, that we do have a really good structure to support this evolution to full risk. I would say right now, based on the poll, we are probably also in the transitional phase, which again, the majority of folks on this webinar are as well. But we are in a good place from a leadership and governance perspective to keep pushing the ball down the field toward full risk. And with that, I will wrap up the MUSC Health portion of the webinar. Thank you so much.
That's great. Thank you, Danielle, Nicole, and Patterson. Thank you so much for sharing your insights and perspectives regarding value-based reimbursement and MUSC's approach to achieving success. These are complex challenges, and success is difficult to achieve, especially with those finite resources you talked about, competing priorities, and various payer reimbursement arrangements that reward both fee-for-service and value-based care. So let's wrap things up with a review of success factors organizations need to consider as they look to achieve quality outcomes and maximize reimbursement. Achieving long-term success with value-based reimbursement is a journey, and it starts with support, leadership, and consistent communication from the highest levels of the organization. Teams need to be aware of these programs and the organization's commitment to this work. Ensuring your organization's QAPI structure facilitates communication and information sharing is key. Multidisciplinary engagement and collaboration, along with aligned incentives, is necessary to be sure teams are working effectively toward the same goals. Oftentimes, providers are incentivized only on productivity or primarily on productivity, and so creating incentives that balance productivity with outcomes in quality, safety, and experience will promote collaboration and coordination of efforts. And then to achieve success in some of these value-based quality measures, hospitals and health systems have to collaborate with insurers, as Kim discussed earlier, also with community resources and post-acute providers to facilitate those safe and appropriate care transitions and prevent unplanned readmissions. And as we heard from our panelists, data and information systems that inform and support this work are imperative. Ensuring sufficient volume of patients, monitoring performance as close to real time as possible, creating technology-supported processes to facilitate best practices, and providing meaningful and timely feedback are all equally important components. The journey to realizing full incentive payments in a value-based reimbursement arrangement is both challenging and complex and requires long-term commitment, support, and focus from administrative and clinical leadership. We sincerely appreciate our colleagues from the Medical University of South Carolina for sharing with us how they are approaching this very important work. This concludes the formal presentation. At this time, we'll jump into our question and answer session and address as many questions as many of your questions as possible. Please continue to answer your questions in the questions pane, and I will ask as many questions on your behalf as time permits. Okay. So now you get to see all the speakers from today. Thank you very much. So let's jump into some questions here. Let's start with, this is for Nicole, I guess, or Danielle. What has been MUSC's most successful approach to using scorecards to communicate performance? So how do you communicate them, the frequency of that communication, the audiences, and the like?
Nicole, you want to take that one? You've done a ton of work. I will say one thing and then let Nicole answer. She did an incredible amount of work in our transplant QAPI program prior to transferring over to the system, and does have a ton of experience on using data to build trust and transparency in our transplant program, which it was years of work, and she's really transferring that skill and work over to the QAPI program. So do you want to elaborate a little bit on that, Nicole?
Sure. I think, sort of the biggest gaps and barriers are when your clinical teams don't believe the data or don't agree on the definitions. And so really defining those KPIs and making sure that you have appropriate numerators and denominators and that you tic-tac-toe through the record and you know that you're getting the data that's approved and accurate and that everybody believes is sort of the first step. And if you, happen to, trip on the curb, you'll pay for it for multiple months later. So pre-planning is important. So I think the cadence is really, to start with, has to be very frequent. And a lot of that pre-planning to build the scorecards out with the collaboration of the team and sort of directing the team to where you need to go by defining those KPIs is super important. Once the scorecards are established, then you can actually use them to do the work. And having the frequent meetings can go from, monthly to now in our transplant teams, we meet quarterly because we were able to put out a newsletter on a monthly basis. So you sort of mature over time. And I think that's the benefit, and all of the team can respond and understand that their hard work at the beginning really pays off when you're actually able to use that data. And then you can go with bigger chunks of time in between to do that process improvement and then really see the needle move. And that's where the big satisfaction is. So those would be my tips, is a lot of work up front, and then as you get more mature, you're able to space things out.
And just as a follow-up to that, Nicole, so it sounds like you're sharing these dashboards on a monthly basis. Who gets to see those dashboards? Who are you sharing those with?
Anybody who will look at data with us, we share with. So we want everybody to be in there and have their arms deep in it. And my most exciting thing that I see is when operational leaders and clinical leaders then take that data and do something with it or represent it or even collect their own data on their own, and we can roll that into QAPIs. So we're at a level of maturity in some of our QAPIs where we have the operational leaders sort of doing, I don't want to say doing quality's work, but we're able to guide them through that process where they're really owning it and making their own changes based on data. So it's kind of all collectively developing that maturity with an understanding of how you look at your KPIs and then how you action them. And so basically the short answer is anybody who will look at data, we'll show it to them. Even the folks on the floor, I love having nurses at the bedside when we can really dig into their data and look at specific cases. I think it's more meaningful than looking at a trend when you can actually see your unit specific data on an individual level and see how we can improve things in the system. And so that's my short answer. But on the large answer, looking at the trends over time, obviously the ICE is responsible for having those overarching improvements in their KPIs over time.
That's great. Thank you. What about, let's talk a little bit about the technology and best practice alerts and clinical variation. In our experience, some providers are reluctant to use cookie cutter care, right? And are slow to adopt clinical pathways or best practices. How has MUSC overcome some of those challenges and encouraged adoption of clinical pathways to reduce that clinical variation? And I think maybe Danielle, you can answer that question for us.
Yeah, I think one advantage that we do have is we have been on a single longitudinal EMR for almost a decade. And so I think the ease of use of the EMR at this point has definitely aided in that. We do monitor best practice alerts and try to remove nuisance alerts, and obviously only build those that are completely relevant, and then target them to specific end users so they're not, flying across 10 different disciplines. For example, so as we all know, it takes a ton of work to get really good at that, but making it a priority and, honing in on clicks and, usability of the EMR makes a big difference. As far as adoption of evidence-based pathways, protocols, et cetera, I think one area of strength for MUSC that has also been helpful in adoption is we've never outsourced that skill. And what I mean by that is we do have a homegrown team called the Value Institute that actually works with the end users and stakeholders to develop those pathways. So they pull all the literature, bring it all together, grade it, and then present it to the clinical team. So a great example of this that we're recently rolled out was heart failure. So if you just sort of take an off-the-shelf product and shove it at a cardiologist, that's probably not going to work as well as, taking multiple different sources, especially the primary literature, and saying, how are we going to implement, goal-directed medical therapy here at MUSC Health? Because I know we're very special and our patients are really sick here. And so really engaging them at the front end. It takes a lot of work at the front end, but the engagement is so much higher, as you progress. And then you sort of get the stamp of approval, if you will, from the Value Institute, and they know that it was, made in the USA, if you will, and they have a lot more confidence in the content. As well, we measure compliance, and we do have dashboards measuring compliance for those Value Institute-derived pathways and protocols, so we can show not only are people using them or not, but we're also using Vizient to compare outcomes in patients with or without protocols, which also makes a big difference, because then you can say, well, your colleagues are using it and their outcomes are better. So can you just press this button and go this direction so we can all get on the same page? So I think that's those are some of the elements that we've used to try to get folks to reduce unnecessary variation.
That's great. I like to hear that. And I think our experience is similar in that you get a few key providers who are either formal or informal leaders who can get their team to come along and show them that it can benefit the work that they're doing and benefit their patients, and get more buy-in from that regard.
For sure.
Nicole, can you talk a little bit more about the role of the quality safety managers? I think that's a role that perhaps not many organizations have. So talk about how what their role is, how you paid for them. Is it FTE neutral? Can you talk a little bit about that?
Sure. So this was kind of a product of some reorganization within the quality and safety department. So it was really, for the most part, FTE neutral. Maybe a little stretch there in some of the areas, but we really try to make it FTE neutral by moving things around. So having, sort of these distinct positions that were, say, for just looking at falls or just looking at wounds or something like that, we actually flipped those roles to make them more of a generalist. And so we put them in the individual ICEs or service lines to allow that work on the horizontal and the vertical, and then the cross-pollination. So we're actually able to take those kind of clinical experts and embed them in the QAPIs and use their expertise on the horizontal as well as the vertical. And so the quality and safety managers really are truly embedded in their teams. I may be their leader on paper, but overarchingly, they're an extension of the individual ICE. And so they are a tool in their toolbox to use for anything that they want to do. And so commonly, it's really a matter of sort of laying out their strategic plan from a quality and safety perspective, and having the QSM sort of go and me help with the barriers along with the rest of this team to help the ICE be successful in their quality and safety journey, and then also cross-pollinate to sort of catalyze our results in a much quicker fashion. I think we've had some overarching early wins with that, change in plan. But Dr. Scher, please jump in if I misspoke.
And the only thing I was going to add to that is we are being very thoughtful and purposeful about their training and career development plan. So we do have a career ladder for our quality safety managers so that, you know, they don't, I think sometimes in quality people get in a position and then they always look for their next position. And what we're trying to do is give them a career ladder, but keep them, you know, within the quality safety manager role. As well, developing a core curriculum for them so they feel very connected, again, to their career progression. So making sure they have, you know, Lean Six Sigma belt trainings and maybe even some Baldrige type training and other, you know, core curriculum for a typical quality safety manager role. And they're all learning and growing together, but they're building on their own career ladder. So I think that's also going to be a really important piece of retention for our team members. So that's an area that's always, I would say, an opportunity or threat for a quality team at a manager level. And so we're really trying to guard against that as well.
Well, that's great. That's great information. There was on one of your slides, Nicole, you referenced MUSC, MEWS rounds. Would you describe those for us and tell us what MUSC stands for?
Sure. So that's one of the scoring tools that looks at patient acuity over time. So our nursing staff enters that every 4 hours on our patients on the floors, and we have a kind of code prevention team or rapid response prevention team of nurses that round on these patients. So as their MUSC score goes up, they're triggered in the system for our sort of early warning system. So we have these rapid response nurses that are able to go to the floor and then help triage at the bedside if there needs to be an escalation of care or if anything in addition needs to be done. So what it really is sort of an example of how we're using existing structures within our system to further, I don't want to say agenda, but I'll say it anyway, further our agenda for our sepsis work. And so, you know, a lot of what we're seeing with these rapid responses is sepsis. And so using these nurses and training them on the new sepsis bundle elements, including our newly formulated order set that reduces care variation and ensures that we adhere to the bundle, we can use them as extenders at the bedside to help facilitate our physician partners to implement those action plans quicker and hopefully reduce our in-hospital mortality. So it was kind of an example of something that already exists in our system that we're trying to, for lack of a better term, exploit that resource in order to help our patients.
And how long have you been using that? How long has that process been in place?
So that's fairly new. So we, you know, after we kind of went through the evolution of looking at the sepsis bundle and all of the issues that we have with it, and with the revision of the order set, we're finally in that phase to roll that out. So we're actually rolling out this MUSC action with our team this week. Actually, we're meeting with that leader. And so we've been in discussions with the leader of the rapid response nursing team for the past few weeks, sort of planting these seeds. So he is on board, and we're going to orient all of his team members to help us roll this out on the floor. That's the one gap that we had as far as sepsis goes. You know, sepsis in the ED is a little bit more contained, if you will, with the players, and on the floor, it's just a broad group of folks. So we needed to have a small partner that could go around and either, you know, sort of gather reconnaissance or infiltrate the area, if you will, to use some military terms, I guess, and really see if we could use those protocols in a much quicker fashion.
Awesome, that's great. I like the analogies since you are in, you know, Charleston. Danielle, you know, one of the things that we hear from clinicians is that they want to provide great patient care, high quality, high safety, good outcomes. They're not so interested in the financial implications of that, right? So how do you navigate the conversation with clinicians around quality, safety, and outcomes with, oh, by the way, there's also an incentive payment that comes along with doing this well?
Yeah, I would say two things, because there's sort of the rankings piece, you know, what do you look like on paper, and then there's the actual payment piece, and they're both, you know, obviously really important, but you're right, it's hard for, you know, a frontline care team member to really focus on those things. So we do try to, the way we try to message it is, we want the world to be able to see the great care that we're giving every day. We already know you're giving great care, but the rest of the world can't see that unless we translate it into these types of, say these words or put it in this part of the medical record so that the rest of the world can see what we see, which is great care being provided every day by you. So that's sort of the ranking documentation kind of piece. And then on the finance side, a lot of the conversation really is around resources, that, there is a limited amount of revenue coming in from run-of-the-mill patient care. And in order to, fill that, bridge that gap between the old world, which is we just get paid for doing stuff, into the new world, which is we only get paid if this part looks good. So the only way that we can get better staffing on nursing units or get more quality officers or whatever it is that we need to deliver great care, really the only way in this day and age to do that is through quality. And so we really try to put it back in their language. As I mentioned during COVID, one of the, I think, toughest parts for our team members that they echoed loud and clear on our employee engagement survey was staffing and stress. And so again, and those go hand in hand, because if the staffing is low, the stress is high. And so we, again, try to couch it into language that they've already expressed to us, which is, look, we hear your words, we're listening to you, this is what the survey says. This is the way to close those gaps, is to really, get these numbers up so that we can get reimbursed for the money that we deserve, that because the landscape has changed.
That's great. That's helpful. You guys have done a lot of work in the quality space. You've gotten a lot of really good traction. You're still focused on a number of improvement areas. What achievement in the quality space are you most proud of? And I guess, Danielle, you can answer that.
Yeah, I mean, honestly, I would say a lot of our population health work, in particular, our accountable care organization through Medicare Shared Savings Program has been tremendously successful. And I think what's so fun to watch about it is, just like you said, like, our team members want to feel like they're giving really good care. And in the old world, it was very transactional, right? So you see a patient, you get paid for what you do during that face-to-face interaction. And now you can get paid for actually longitudinal care, which feels good, right? I mean, you feel like you're doing the right thing. You're doing medication reconciliation. You're doing discharge follow-up phone calls. I mean, this all feels like good care. And so I do think that's probably what we would, be most proud of, is that we feel like we're giving better care and getting paid differently at the same time. And we've done really well in our ACO. I mean, we put in the infrastructure and governance and skill set required to be successful, and that really lends itself to, other payment type, value programs. When you figure it out and you get the infrastructure in place, all these other things, you can sort of, all the challenge that I listed earlier in the webinar, those things all become easier once you get the infrastructure in place. So I would say our, population health ACO efforts have been tremendously successful and frankly fun to watch.
That's great. Well, thank you for that. This concludes today's program. Thank you very much, all of you, for participating. We really appreciate your time and your expertise. And please note that if you asked a question that we were unable to get to, we will follow up with you after the session. We hope you will join us for future webinars, and would also like to make you aware of ECG's extensive library of thought leadership. Please visit our website at www.ecgmc.com to learn more about our upcoming webinars and about these relevant and timely topics. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handouts. One final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a good day.